Hello and welcome to Heart Matters Live. I'm Fergal McKinney, head of British Heart Foundation, Northern Ireland. Heart Matters Live is BHF's free, expert-led Q&A series. Every 3 months we bring you a live session where you'll hear from people with specialist knowledge, whether that's BHF-funded researchers, clinicians, or people with lived experience, and get a chance to ask them your questions. Each session is centered on a different topic, and today we're focusing on artificial intelligence and the growing role it's playing in heart care. From helping doctors interpret scans and tests more accurately, to identifying people at risk of future heart problems, AI has the potential to transform how we diagnose, prevent, and treat cardiovascular disease. In just a moment, we'll be hearing from Dr. Hesham Aggour, a cardiologist and researcher based at Imperial College London. He's going to be sharing some of the exciting work being carried out by his team into how artificial intelligence could uncover new insights from routine ECGs, helping doctors detect heart disease earlier and better predict future health risks. We're also delighted to be joined by Dr. Mike Dodd, who is going to share his personal experience of living with uncertainty about his future heart health. Mike carries a genetic variant associated with hypertrophic cardiomyopathy, or HCM, which is a condition that can cause the heart muscle to thicken and affect how well it functions. Although his heart currently appears healthy, he requires lifelong monitoring and faces the possibility of developing the condition in the future. We'll hear from Mike in just a moment. Before I hand over to our speakers today, if you have any questions for Mike or Hesham, please do submit them via the Q&A function throughout the session. We'll put a selection of these to our speakers at the end. Just a quick note to say, if you've personal questions about your own health, please contact our heart helpline and speak directly to one of our cardiac nurses. Details of how to get in touch will be shared in the chat. During this session, please only submit questions that are directly for our speakers or related to the subject. Thank you. Now, without further ado, it's my pleasure to introduce Mike, who's kindly going to share his story with us today. Mike, thank you very much for being here. And Mike will be interviewed by Yana Theodoro from the BHF Heart Stories team. Mike and Yana, over to you.
Thanks, Fergal. And hi, Mike. Thank you so much for being here and for kindly sharing your story with our audience today. To start us off, could you tell us a little bit about yourself and your family's connection to hypertrophic cardiomyopathy, and maybe explain what that condition is?
Yeah, perfect. So I'm Mike, I'm actually a cardiac researcher, and it really comes back to the reason I'm a cardiac researcher is because of this family history. So hypertrophic cardiomyopathy means that the left ventricle, so the main part of the heart that pumps blood to the rest of your body, becomes thicker, and that can make it more difficult to work, and it increases risk of complications such as dangerous heart rhythms, so arrhythmia, but can also lead to worse outcomes such as sudden cardiac death. So I carry a genetic variant, same as my dad and lots of members of my family, which means that I could develop the actual condition and have the thickening heart. But at the moment, my heart appears normal structurally and appears to work normally, but uncertain for the future.
Thank you. And so growing up, what was it like watching your dad go through heart problems and learning that this could be something that was inherited within your family?
So I found out that my dad had heart problems when I was, I think, 14. So that was what, 36 years ago. I'm not 36, I'm giving myself age, 26 years ago. It's my birthday tomorrow. Anyway, I think, I remember my dad having the atrial fibrillation, so the fluttering, waking up scared in the night, having had an ectopic beat, so an extra beat, or that process of feeling his heart and feeling unusual, and being worried about what was wrong with my dad. My dad was a policeman, a very strong man, and to see him scared and worried really was quite upsetting, especially as a teenager. I found out when I was at school, I got a phone call through and said I can't continue doing cross country that day because might have a heart condition that could lead to, risks of, dangerous heart rhythm or that the sudden cardiac death. So I had to stop, and it took a while until I was able to be seen by a doctor and actually my heart checked. So I think to start with, scared, worried about what the future hold, and also not knowing initially what was wrong with my dad. They said, oh, there's this thickening. He's seen a picture through the echo and shown that his heart's thicker, but what does that mean? What could cause it? So yeah, I think initially worried and scared, but also then interested in the heart. It kind of got me passionate about knowing more about the heart, and the reason why I wanted to be a cardiac researcher was because I had this interest from 14 about what the heart does, how it works, what might go wrong, and so we kind of delved into that.
It's so close to your personal experience.
Yeah, definitely.
And so you were only a teenager when Dr. Stutz first started monitoring you. How did this affect you at that age? Because obviously 14 is such like a formative age.
So I think I guess initially, as I said, kind of scared, worried, kind of a bit unsure about what it might mean, what the impact might be. But I do remember, I think, from a point of view of always being curious and being driven by wanting to know more. I think that first time when I went into the hospital, I was quite nervous. But then they took an ultrasound of my heart and showed me a video of my heart beating, and that was the point where I was like, this is amazing. This is my heart inside my body. I can see the heart beating. You can feel it, but this is there. It's there. It's a picture. And I remember being relieved because they said structurally the heart looks normal, the ECG looked normal. So for now I need monitoring, but at that point they said you don't have a thickening that your dad does, and that other members of my family eventually were diagnosed with as well.
And so when testing became available to you, you made the decision to find out whether you carried this genetic variant or mutation. Can you talk a little bit about how you came to that decision?
So I had a chat with the cardiologist at Oxford who was looking after my family and my dad's extended family. My dad was 7, so there's lots of aunts and uncles. And at that time he suggested that actually genetic testing was available. I was, I think, 22, 23, doing my PhD at the time, and said, this is available, but it'd be a good idea to go and talk to the BHF-funded genetics counsellor and genetics nurse to talk about what the impact might be. It's not just going ahead and doing the test and going, great, I don't have the gene, or I do have the genetic variant. It's what could the impact be? Is it going to solve any of the problems? Is it going to help alleviate any of the worry that I might have? It's difficult because I think, I initially said, well, if the genetic test shows I don't have that variant, then I'm not ever going to get the condition the same as my dad. But if I did have it, it doesn't mean that I'm definitely going to get the condition. So it doesn't, if it was negative, then yay, I don't necessarily have it. If it's positive, it doesn't mean I'm definitely going to get the condition. It just means I'm at greater risk. Mm-hmm. I think it was a big decision. I was quite scared, but also I think I was a little bit flippant sometimes. I was like, oh, it's fine. I don't have, my scans have been normal all these years, the last 7 or 8 years since at that point. They've been absolutely normal. So the genetic test is going to come back normal as well. And so I remember the day that I found out the results, I was shocked. I was upset. I was sat at my desk at work, and the email popped up. I read it and I ran away. I ran off to the coffee shop, and 2 of my lab friends came out and had a chat with me. And I think I actually started to process what it meant. I think at that point, because he'd been monitored yearly, kind of went, it's fine. But that's it's probably more than 12, 15 years since I've had that. And I think now it's just that continual monitoring and knowing that my heart looks normal, it beats normally. And so, the genetic test doesn't give you the answer that I'm definitely going to have the disease.
Yeah, I mean, that's the thing that we keep coming back to, isn't it? Is that uncertainty, because you carry the same mutation as your dad, yet your heart currently appears healthy, and you may never develop the condition at all. So, like, how do you live with that uncertainty, and how does it affect your day-to-day life?
So I think, it makes me more aware of my heart. It makes me more aware when I've had, it's not connected, but if I've had too much coffee, I might feel my heart racing slightly, and I start to worry. But actually, no, it's just normal response to caffeine. Or I might have an extra beat where the heart, has a bit of an adrenaline rush. You have an extra beat, but that happens. That's a normal part of everyday heart beating. It can happen. It doesn't happen every day. It doesn't happen all the time. It happens once in a while. But because I'm so aware of my heart, I become more aware of any of these little changes or things that I worry might be the sign of something to come. And so it stresses me out. But other times I think just this is normal. And I guess having had that training of doing what I do, I become more aware of, yes, okay, this is normal, but it still doesn't stop me from thinking about my heart beating and feeling it and being worried about it.
Mm-hmm. And of course, the sort of like added element to this is you are now a parent. You have two daughters, which has brought a whole different perspective. So how has having daughters changed the way you think about your genetic risk? You've chosen not to have your daughters genetically tested yet, but they are being monitored. So how did you and your family come to that decision?
So I think that was a really tough decision. So like I've had to give up things in the past. For example, when I started university, I got the opportunity to row. I'd never had that opportunity before, but that was something that I got told I had to stop because it put too much strain on my heart, and it could unveil something that was present. And so I worry about my daughters. I worry about them. One that's 5 and one that's 11. So I worry when they want to do sport, when they want to do things about how they might push themselves. We had genetic counselling before our eldest was born, and they discussed about the fact that we could have testing in utero, so when she was before she was born. But ultimately, we felt that I have the genetic variant, but I don't have the disease yet. So just because that they have the genetic risk doesn't mean that they're going to get the disease. And ultimately, we kind of came to the conclusion that it's their DNA, it's their genetic information, and that they need to be old enough to know that they're happy to understand that and see that and really appreciate the impact of finding out would be. We could have, we could still do it now, but I think we want to wait until they're older. My eldest is now going through the same monitoring that I have. So she's seen every year to 2 years in the John Radcliffe in Oxford. And yeah, she has perfectly normal heart at the moment. But the same feelings I had before, which was if it's negative, they don't have the gene variant, then there's no need to worry in that way anymore. But it's really tricky because I don't want to limit what they can do, but I also don't want to put them at an adverse risk. I don't want to stress their heart out. I don't want to have what you see sometimes with people with HCM. I want them to be safe, but the genetic test isn't necessarily going to give me that reassurance. And that continual monitoring probably will.
Mm-hmm. And are there things that, most parents probably never think about that you find yourself considering or thinking about because of the condition or the risk to this condition?
Yeah, I've taken my daughter into hospital once because she had her heart was racing after I think she'd had COVID before, and then she got ill, and then she'd had a bout of illness, and then her heart was racing. So I was, it was fine, but I became very worried, and so I took her straight into A&E to get her checked over. And by the way, she's dehydrated. It's fine. She's got a little bit ill, but it's ultimately fine. But my brain automatically went to the worst case scenario. What if something's going wrong? What if this is the first sign of something to come? And so, yeah, that was stressful. And I guess you overplay some things in your mind. You worry about it. So yeah, I think stressful.
I know you've been, very sure about the school having defibs and knowing where they are and things like that.
Yeah, so we looked the 2 secondary schools that my eldest has applied to as going to. Yeah, we contacted the school and said, like, where do you have access to a defibrillator, or is there one close by? Also, use some online tools that showed us where they were positioned, because ultimately, if she passes out, if I pass out, then potentially, this could be a risk of HCM complication, and that the defibrillator is what's needed in order to bring me back to life. So yeah, so sometimes I think I worry a bit too much about that, but I think having my kind of background, I'm a bit more conscious about that, I think.
I think it's hard not to, given the circumstances.
Definitely.
And you you told me that you spent years thinking about, why some people who have this genetic variant or mutation develop the disease and others don't. Why is that question so important to you? And like, what excites you most about the possibility of AI helping researchers uncover answers to questions like that?
So yeah, I think it's just that uncertainty is in, like, yes, I have the same genetic variant as my dad, as some of my cousins and my aunts and uncles who have the thickening of the heart, who have had that risk and the scares, and yet I don't have that. And I got to, I'm going to continue monitored apparently now until at least 55, maybe older, maybe for my entire life. But if I could know more about what is that risk, could technology now look at my ECG? Could it look at my images from MRI or echo and go, okay, yes, when you look at it on the face value, absolutely normal, but actually there are subtle differences that in later life might increase that risk. And then maybe unlock future, technologies or drug access to drugs that might help treat it, or something that might help in the future. Kind of that uncertainty of maybe I'll never get it, and so I don't need to worry about that. But equally, maybe I will. And at the moment, we're not able to pick up the subtle differences that are hidden in my images and my ECG.
Mm. And so we're about to hear from Dr. Hesham Aggour about his team's research. If AI could one day identify subtle changes, years before symptoms appear, what difference could that make to people like you and your family?
I think it could just, it's probably similar to the genetic testing, almost like that. So like if it showed that actually the risk in the future would be relatively low, then it might put my mind at ease a little bit. If it showed it was increased, then maybe it would change the way that I look at things and look at the way that maybe my daughters don't do karate, or they don't do gymnastics, or they do it, but they just don't try and push for, the top level in those sports. I think maybe putting that mind, the mind at rest, just knowing one way or another, knowing a bit more. The more information I can have, the more understanding, and the easier it puts my mind at rest.
And just lastly, if there's anybody watching who's going through a similar situation, maybe they've been through it, maybe they're going through it right now, what sort of advice or words of support would you offer them?
I always go back to Hitchhiker's Guide to the Galaxy and say, don't panic. I think, just because I had that genetic test, just because it showed that I carried the genetic variant, doesn't mean that I have the disease, have HCM, or will get HCM in the future. I may never get it, I may still get it, but we have amazing doctors, nurses, teams here in the UK that are amazing at supportive. I always enjoy going to the cardiology department, talking to all the team that are there, slightly on a geeky side by being a scientist, but also from a point of view of feeling relieved, of knowing that they're always thinking about the next steps, talking to the doctors about what treatments might be available in the future, or what the best thing for my family might be. I think, talking about it, being open, and not worrying. I know I say that, and I've talked about being worried a couple of times already, but I think it's just, don't panic. And I think understand that it's not the end of the world. We can go through this together, and there's always opportunities to discuss it with either doctors, nurses, or with things like the genetic counselors as well.
Mm-hmm. Well, thank you so much, and I'm sure people just hearing your story and hearing you share it so openly is so helpful as well. So thank you so much for sharing that with us.
It's okay.
Fergal, that's back over to you.
Thank you, Mike and Jana. And Mike, can I add to thank you for sharing your story so openly and honestly. Now, I'd like to introduce Dr. Hesham Aggour. Hesham is going to give us an insight into the exciting AI research he and his team have been doing. Welcome, Hesham. Over to you.
Thank you very much, Fergal, and thank you, Mike, of course, for sharing your experience. Good afternoon, everyone. Thank you very much for having me speak here today. My name is Hesham. I'm a cardiology doctor by background, and I'm a BHF-funded clinical research fellow at Imperial College London. And today I would like to talk to you about how we are applying artificial intelligence, or AI, to a very common heart test called an electrocardiogram, or an ECG, and how that is potentially going to transform the use of the ECG in identifying and hopefully preventing heart disease. We know that there are 8 million people in the UK who are currently living with heart or circulatory condition, and the BHF estimates that more than half of us will develop one sort of a heart condition or circulatory condition in our lifetime. And therefore, heart disease in general is a very important problem that still needs to be addressed, despite all the progress that we've made in clinical medicine over the last 10 years. And there is an uncomfortable reality. Most diseases such as high blood pressure and diabetes get diagnosed once someone already developed symptoms, after the disease has run its course for potentially years. And some conditions such as heart failure, where your heart is weak and not pumping very well, they unfortunately go undiagnosed for a long time, and people only find out when they end up being very unwell and get admitted to hospital. And that's at that point where we actually identify these diseases. And usually at that point, we are just merely managing the disease rather than preventing it. And if we want to get ahead of that curve, we need something that works on people who effectively feel well, and to identify these diseases before it actually presents itself. And therefore, there is a vital need to develop new tools in clinical practice to address this problem, which will affect all of us. So what is an ECG, or an electrocardiogram? It's a very simple test that's been there for over 100 years, and it won a Nobel Prize for its development. Every heartbeat begins as an electrical impulse, and that electricity is transmitted through the skin, which can be captured and recorded. And it's a very quick, painless, and cheap test. There's one in nearly every GP practice, even ambulance cars and hospitals across the country. And now even there's a version of it on a lot of people's wrists, such as fitness trackers and smartwatches. And this is what an ECG looks like. This is a real ECG. It has 12 views of the same heart. If you ever had one, this is what would have gone into your notes. And as clinicians, we spend a lot of time trying to learn how to interpret it. We look at different angles. We look at how far these spikes are stretched out. We can look at what the heart rate is. We can look at what these waves mean and whether they are happening regularly or not so regularly. And we can look at various different things, and each bit actually tell us what is happening within the heart. And it's a whole reading, a few measurements that we do from a 10-second recording, and it has already probably saved millions of lives. People having heart attacks or dangerously slow heart rates or very, very fast arrhythmias. But until now, that's how we only relied on the ECG by expert clinician interpretation. And we believe that this is just the tip of the iceberg, and it's potentially a fraction of what this test can actually offer. So what does the computer see and what AI actually is? And our research, we've developed computer models or AI that can do things that I would like to show you. So for 100 years, the ECG has always been ink on paper, essentially, and the eye can pick up only so much of that printed line. But for the last couple of decades, ECG machines have transformed, and they've been recording the same ECG, but as a digital signal. So lots of numbers, measuring the changes in the heart's electrical activity hundreds of times a second. And you can see how we see it on paper, and actually underneath that trace, there are lots and lots of digital signals and lots of numbers. And we know that computers are really good at reading large amounts of numbers. And think of AI as an extremely efficient computer program that can detect different patterns within numbers. And certainly clinicians cannot do that. What we do is we show millions and millions of these ECGs to the computer program and tell the computer program what has happened to those people or those ECGs afterwards. And it learns how different diseases might manifest within these very hidden signals. But the important bit is that we never actually tell what to look for. We just leave it to detect its own patterns. And it probably picks up patterns that nobody has been ever taught. And patterns are probably too subtle or too small for the human eye to actually see. And this is what we normally mean when we talk about AI. So we don't mean, a robot doctor. We don't mean some kind of weird software that nobody really knows how it works. And that's the idea. And what our group actually did is we gathered lots and lots and lots of these digital ECGs, not just from printouts, but also digital signals from a lot of hospitals and research institutions around the world. We trained and developed these computer programs on these ECG signals, and each recording is paired with what happened to that specific individual so that the computer can learn these patterns about different types of diseases, such as high blood pressure, diabetes, irregular heart rhythms, and so on and so forth. And the next part is what actually matters. Once we've developed these models, we test them on people or ECGs in hospitals and institutions that it actually hasn't seen before in other countries, perhaps, because this is the only way and the only honest way to actually tell whether these models really work. And so far, our research group is really fortunate. We have a global network of collaborations, and we have data from all over the world. We have more than 19 million ECGs from over 1 million patients from 4 continents. And the breadth of data is really important, because what makes these models representable is that it actually sees and captures a breadth of ages, genders, ethnicities, races, and so on. And this is why we try and aim to expand these data sets to make sure that these models are fair. So this is a genuinely exciting bit. So what do these models can actually do? Our work has shown that from a single 12-lead ECG, we can estimate things like someone's age, someone's body mass index or BMI. And we have shown that if your heart looks, let's say, 10 years older than your actual age, that gap carries real information about an individual's potential risk of cardiovascular disease. So it's kind of a way of asking how old the heart actually is rather than how old you are. And perhaps a more useful application is discovering disease that is already present but potentially undiscovered. And we've managed to develop AI models that can identify things like heart failure from a 12-lead ECG before it even causes any symptoms such as breathlessness. We can identify and pick up diseased heart valves, whether these are narrowed valves or leaky valves, which conventionally we would only be able to identify it on an ultrasound scan of the heart or an echocardiogram. Other examples, such as atrial fibrillation, which is one of the commonest rhythm disturbance problems, not just the UK, but worldwide, and it carries a really high risk of developing strokes. Simple things like high blood pressure and diabetes, as I said earlier, might have been ongoing for a very long time, and people only get diagnosed when they start having symptoms from it. And we can do so with very high accuracy, and that accuracy ranges from 80% plus, depending on which disease we are looking for and how well that disease is identified within these subtle signals within an ECG. And I think it's very promising because picking up these conditions in primary care, such as GP surgery, rather than from a hospital bed, is what would enable us to start treatment early and put measures in place to stop those diseases from progressing. And the bit that I find really interesting, and I think this is where AI will be really useful, is that it not only can identify diseases that already exists, but it can actually predict disease before it develops by up to 10 years. So from a simple recording, while someone feels perfectly well, the model can tell us who is likely to develop a condition, such as the ones that I've mentioned earlier and others, in the years ahead. And that really moves the ECG from what it currently is, which is essentially a diagnostic tool, to a prevention tool that we can use on a population scale. And the implications of that are huge. And I think hopefully in the imminent future, two really practical uses of AI ECG would be firstly in screening at a population scale. So as I said, we can identify people at high risk of developing things like blood pressure and diabetes, and we can offer them really customized and personalized lifestyle support advice and potentially interventions to prevent or at least slow the progression of these diseases. And this is usually at no extra cost because the ECG infrastructure is already there. The other example would be reducing waiting times for things like heart investigations and more specifically heart scans. And anyone who's ever needed a heart scan of any sort will know that waiting times are unfortunately not short, and they vary significantly depending on where you are in the country. So if we have a model that can actually tell us which patient or which individual on that list waiting to have an investigation is at a higher risk of having something dangerous, such as a weak heart or a very narrow and tight valve, maybe we can have a more dynamic way of managing these lists, and those patients could get scanned and offered to be seen much earlier. Another example in an area that is genuinely difficult in us clinically, and I think that might mirror what Mike's experience was, in some heart muscle conditions, such as hypertrophic cardiomyopathy, where the heart muscle is particularly thick, or in dilated cardiomyopathy, when the heart muscle is weak and large, those individuals potentially carry risk of developing dangerous heart rhythms in the future. And in some situations, we can offer those patients very advanced therapies. But sometimes making that decision is not clear-cut, and it's very difficult, both for us clinicians and obviously for the patients themselves. And our current risk stratification tools that helps us identify who might be at a potentially higher risk of developing these types of dangerous complications. These tools are quite blunt and they're not very personalized. And actually within our research group, we had work led by some of our students that have actually shown that AI ECG can potentially sharpen that estimate, and incorporating AI ECG with the current risk tools that we already have is really, really useful and can actually offer us a genuinely individualized conversation with patients rather than just offering an individual a general metric or a percentage of potentially developing risk, which is usually based on population studies. And this will really enable us to offer them support, to offer them advanced therapies, to offer them, how long we might potentially need to monitor them for. Do we need to monitor them lifelong? Can we stop seeing them after a certain age? And how frequently do we need to see them? Do we need to see them very often? Do we need to see them every now and again? So that is really, really beneficial. And that would really enable us to have a really personalized way of managing patients. So kind of to put it all together, I think this is how I would hope to see how AI ECG would be incorporated in clinical practice in the maybe not so distant future. So an individual would go to their GP, whether it's for a symptom or simply for a routine check, part of their, let's say, wellness check perhaps. An individual would get an ECG recorded exactly in the same way as they get their height and weight and their blood pressure recorded. Models would be applied to these ECGs, and they flag if there's any specific concern that an expert clinician could not potentially see on a tracing, because usually in these situations, the ECGs are still normal. And because of that flag, an individual would get a more personalized advice, and you might get offered further testing or further assessment in maybe specialized clinics. And when we achieve that, we can actually have a diagnosis that is made before anybody has ever felt any symptoms, and we can start treatment early, which is usually at that point where it does the most good. And I'm sure the obvious question now is, if all of this is true, then why don't we have these tools already in hospitals and in GPs? And there are a variety of reasons, but I think two of the immediate reasons are, firstly, everything that I've described so far has been built by looking at data sets that already exist, by looking kind of backwards in time, by which I mean we studied the records of people whose outcomes we already know, which is usually the right way to discover these type of patterns and prove that these patterns are real. But what it cannot prove is that whether the prediction that we get from AI ECG actually helped us and patients. And to do this, we need to have testing. We need to test these models prospectively or looking forwards, giving the predictions to clinicians in real time in the NHS and comparing it against what a clinician would normally do without AI in a randomized control way. And this is work that we're doing right now, and it's an important step that turns a really clever model into something that works in real world practice. And I think another important reason is that, which is one that really interests me, and it's part of my work, is how reproducible these predictions are. As clinicians, for example, we never really diagnose high blood pressure in most cases from just a single reading. We usually ask patients to take several readings because we know that one reading can move around. You might have seriously high or low readings, and an AI ECG prediction has to face the same testing. And if we record, an ECG for the same individual next week, does it still say the same thing? And if it doesn't, why not? And does that mean anything? And does that mean that we need several recordings from different ECGs to be able to accurately predict what the risk of that disease is? Or can we just rely on a snapshot ECG and you can have just one ECG, one prediction, and that would be reliable? And we have to answer these questions before we can actually use these models in population screening, for example. And to sum up, I think the ECG is a great tool. It hasn't really changed in a really, really long time. It's the same 10-second ECG that we've always recorded, but I think AI has really unlocked its potential, and it really unleashed how much we can benefit from an ECG. And if we can prove that this works prospectively and reliably, I think we can identify cardiovascular diseases early and hopefully help a lot of patients before they even become unwell. Finally, I'd like to thank the British Heart Foundation for having me speak today, and for funding my work, and for my supervisors, Professor Ung and Dr. Sao. And this is just a picture of our research group at Imperial College. And thank you very much for listening, and very happy to take questions.
Thank you, Hesham, and fascinating stuff. And I'm glad you put up the picture of the team too, because this is ultimately teamwork, isn't it? Utilizing this new AI. So, Mike, you're back on screen for our audience Q&A, and now it's your turn. If you have any questions for our speakers today, please pop them into the Q&A box now, and I see many of you have been doing that already. We're going to go on the most upvoted. So you've addressed some of these issues, Hesham, and some of these questions have been in before and during your presentation. So forgive me if I go over some of the territory, but it is worth exploring too. So how accurately can AI assess an ECG to diagnose conditions? How accurate fundamentally is it? And also incorporating another question, how can it be trusted? Can it be completely trusted? You've addressed some of it, but explore more.
Absolutely, thank you. It's a very important and interesting questions. By looking at these retrospective or backwards data sets, we've shown that models work with very, very high accuracy. Depending on what disease we're looking for, we can identify disease by 80% plus, which is really, really good, and it's really, really accurate. And if anything, it kind of outperforms the normal risk scores that we usually use in clinical practice. Having said that, like I said, we haven't really tested that going forwardly and prospectively. So if we know that we can identify these diseases accurately, does identifying these diseases early actually make a difference? And how do clinicians use these predictions? And to answer the second questions, your second question, there's a lot of work going around the explainability or the interpretability of AI in general. And we know generally that the better the AI tools that we use, or the computer program that we use, the slightly less explainable we know, or in other words, we don't really know how it comes to the patterns that it identifies. So let's say it identifies a specific pattern that can tell it that this person has a high risk of having heart failure. We don't know how it came to these patterns, but what we do know is that there is biological plausibility to this. So in a lot of our work, we look at how these AI ECG predictions correlate or relate in general to things like genetics, to different phenotypes. So for example, if someone has a high risk of having, if a model tells us that someone's a high risk of having heart failure, the predictions relate to parameters that we actually see on ultrasound scans of the heart, such as big sides left chambers, or leaky valves, or specific changes on ECGs that we conventionally know that actually correlate to having these outcomes. But there's a lot of work going on around the explainability of these models, and how we can get clinicians to actually trust the outputs of these models.
Yeah, another question. It's obviously, if it can predict someone's future risk of heart disease, what can doctors do with the information? But specifically, they're reaching forward here. They're testing already. What could it help prevent heart disease from developing in the first place, given the length of time you're saying it can predict to?
So obviously, that's the overall goal. I think we will have to incorporate this with other research in different fields, such as genetics. Genetics is a really important research field that actually complements risk prediction in general. So as you said, if we know that an individual might potentially develop a disease 5 years earlier, what can we do now beyond the conventional treatment that we do have available now? Can we offer those individuals to actually change their course, whether it slows it down so it develops after a longer time, or completely stop it? And I think it depends on what kind of disease we're looking at.
Yeah, of course. Mike, has being monitored regularly provided reassurance, or can it sometimes increase anxiety?
I think it's a bit of a bit mixture. So most of the time it's I'm I will go, they'll say my heart is fine, and then I feel less anxious. I do sometimes feel anxious when I'm sitting there because I'm having, on that day I'll have an ECG, I'll have an echo, so an ultrasound of my heart. I'll then sit in the waiting room and wait for the cardiologist to have a look. And at that time, the anxiety can be quite high because I start to worry, well, what if this is the time that I find out that the heart is thickening, that there is a difference? But I find it reassuring seeing it in my calendar. It swaps between every year to every 2 years now, because I'm at lower risk. So I find that reassuring. I'm like, I can see that it's in January 2028 is the next time, and I know that that's good. But equally, when I'm there, I do get a bit anxious. I do worry about what it might show. And I do sometimes try and look at the echo when they're taking it to see what I can see. But equally, I don't know much about the human heart, so it'd be difficult in that setting. But yeah, I think a bit of both. It's reassuring to have it there and to know that I'm monitored and checked by some amazing clinicians.
Hesham, I'm amazed at the scale of what it is you're doing in terms of the numbers of people and the ECGs. But one questioner here says, will it work equally well for everyone, regardless of age, sex, or ethnicity, etc.?
So this is an excellent question, and I think this is exactly why we aim to diversify our data sets that the models are trained on. So as I've shown, we started with just a UK biobank data set and a US data set, but you've seen that over the last few years we've expanded that broadly. We are still looking to test this on different populations that the models haven't been really exposed for, and obviously more importantly within real world NHS data sets, which is what we are currently doing at the moment.
Okay, and if this tool can predict the future cardiac health of someone, now this leads into more infrastructural question as well. What will need to change about the NHS infrastructure to support people in prevention or support them with serious heart conditions? So, you need to match it with structure.
Absolutely. I mean, this is a very good question, and it's very broad. I think from the AI ECG perspective, there are two main challenges. One, I've shown you that most of this work has been done on digital ECGs, where we record the signals digitally. In the NHS, the majority of NHS trusts actually have still what we call kind of old school paper ECGs that have been scanned, which we've had to develop specific models to be able to read those signals because they work in different ways. So one challenge is actually unifying that standard and having digital ECGs incorporated across the board, whether it's at primary care, paramedics, and hospitals. And that would enable us to offer real-time prediction, because transferring image files are much bigger than digital ECGs, and transferring that, ensuring data privacy and clinician direct oversight is a big challenge. So I think one challenge is actually digitizing our infrastructure, more support and more funding to incorporate this technology in primary care, I think, because this is where the maximum benefit that we might achieve from this technology.
Okay. Mike, for you, and maybe as well, Hesham, you could come in on this because you'll have experience of talking to people. But how do you balance staying informed about risk without letting it dominate your life?
It can be tricky. I think, I said when I was interviewing that, I've had to give up things in the past because there might be a risk that it could stress my heart out. It might not, but I didn't want to take that risk. And so sometimes that can be a bit disappointing. It can be a bit worrying. It can also sometimes make, I think when I become slightly more aware of my heart, it might be, I get a random beat at the end of a night or a long day where I haven't slept much or I drank too much coffee. And as I said, sometimes those are perfectly normal, but you think them a bit more, you worry a bit more about it. But generally, I just don't let it worry me. I said I do my research on the heart because I want to know more about the heart. I want to understand more. But I just try not to think about it all the time. But it does creep in. It does, there's the odd time when it twinges, when it goes a bit fast, when you get a bit of adrenaline rush, and I worry, but I just think, I'm monitored regularly. This, my heart is normal. I've only been seen recently in January, so it's unlikely that my heart has rapidly expanded that quickly. So yeah, just balance up that risk.
Yeah. Have you just to change that question a wee bit ago? Is that something you measure? Do you survey people about how they feel about this?
Yes, absolutely. So health anxieties in general, and specifically within AI ECG prediction, is a real challenge. In our group, we are really lucky because we have a community steering group who kind of helps us shape how we explain to people what these models are doing and how these predictions get interpreted in clinical practice. And I think it's something that we will have to deal with as clinicians going forward. And it already exists outside of the AI world. So now everybody has a fitness tracker of some sort. They get all sorts of different notifications that may or may not be meaningful. And healthcare in general is seeing a large influx of this health anxiety, and we're slowly learning how to manage it. And I think it really depends on individuals, and it really depends on which setting we actually incorporate and deploy this technology in.
Okay. If a lot of people are predicting the future, if you like, in some of this too, but certainly the issues around. But if you have a heart condition of any sort, should your family always be checked out in this way?
I think it depends obviously on the heart condition. Some conditions we know for a fact that has a very strong familial and genetic basis, such as hypertrophic cardiomyopathy, for example. And some conditions are multifactorial. There might potentially be a genetic element, but also there are environmental factors, there are lifestyle factors. And that's why having a personalized care plan, regardless of the condition, is really important. So each individual patient, depending on what their specific circumstances, what their actual condition is, they should have more personalized advice, as in what they should do and what their family should do. And that's why I think incorporating AI in general will be really useful in that.
Okay. Let me just get to another question. Is there a potential link to other diseases, like dementia, for example, that might emerge as detectable as the models become more sophisticated?
I mean, certainly, yes. Obviously, our work is focused mainly on applying AI to just the ECG. There is a lot of work on applying AI to imaging, such as brain imaging, heart imaging, and there are specific patterns that sometimes we see. So, for example, we know that having a condition such as atrial fibrillation or irregular heart rhythm has a potential high stroke risk in patients. But also we know that there is a link between that and a condition called vascular dementia, which is dementia, but mainly because of the blood vessels in the brain becoming very stiff. And nowadays, I haven't really talked about this, but nowadays there's a new concept in AI called multimodal AI, where you develop a program that doesn't just look at one specific test, such as the ECG. It incorporates so many different things. So it can look at the ECG, heart imaging, brain imaging, health records for patients, how they presented and what their family history is, and incorporating all of this together in telling us who is at risk of a wide variety of disease. So that is what is currently happening in the AI field, research-wise.
Okay. And then, given that somebody who feels well wouldn't be going for an ECG, but could in time develop heart disease, could this be used ultimately as a screening tool?
I think this is the holy grail. I think, as I've mentioned, I'd like to see it incorporated in primary care predominantly, and in things like, your wellness check, where you go have your blood pressure measured, basic blood tests. You'd also get an ECG, and that would be part of your population screening, and that would help us identify patients who might have not been caught by the standard blood pressure reading, height and weight measurements, and then we can see them more frequently or offer them more lifestyle advice and maybe start them on treatment that we wouldn't have normally started them on at that point.
Okay. Mike, while you're in the middle of this, does this excite you as a prospect, particularly given that you've talked about your daughters too?
Yes, I found that really interesting, that talk. I found it really interesting, the research going on. And yeah, I could see, that excitement in the future about, looking at those ECGs. I've got ECGs in the hospital since I was 14. So our family records were about that thick whenever they go in there, because I said my dad is one of 7. So there's lots of family history. There's lots of going on. And I think, yes, it would be really interesting to know more about, what that might mean. And again, as you said about my daughters, understanding that risk, could there be something that picks up something that might happen in adolescence or early age that actually might mean that we could reduce some of their sports or some of their activity that might put extra strain on their heart, and just make them a bit more aware about what it might feel like, or why it might, how they could get ill. So yes, definitely, I could see that being, having an impact and being something really exciting for the future.
Thanks, Mike. We had a question on the trust, Hesham, earlier on about the information and the prediction. What about the personal information in terms of assessing more broadly? What safeguards are there in there?
Yes, absolutely. So I think I've mentioned earlier, data privacy is really important, and anybody who have been exposed to AI knows that AI is very, very data hungry. But we need to make sure that this data is regulated. And that's why, for example, all of the research that we do has very specific ways how we transfer data. So for example, within the NHS, all of the information becomes anonymized on the local NHS servers, so researchers don't actually know who the individual patients are. They can see patterns, so they can see, what's the rate of high blood pressure in this NHS cohort, for example, but they can't identify who these individuals are. And as we move forward to actually prospectively testing these in real-world clinical practice, one of the main questions that really comes up every time is that how are we going to ensure that this data privacy is maintained? And is it going to be processed on the cloud, for example? Is it going to be processed locally on NHS trusts, and therefore the data doesn't actually leave hospitals? These are all things that we are actually trying to navigate as we are building and developing the clinical trials that actually test these models in clinical practice. So it's an important challenge. It's a very, very important challenge.
Well, that's all we have time for today. Mike, thank you very much for sharing your story so openly. Hesham, thank you for sharing the future. I suppose is really, because this is just going to be something we'll focus on more and more over time, and best wishes for all your work going forward. As I say, that's all we have time for today. If we haven't managed to answer your questions, then we encourage you to call our Heart Helpline and speak directly to one of our cardiac nurses. Heart Matters Live is a free quarterly Q&A series, and we strive to produce the best live events possible. Your feedback and comments are crucial to help plan and develop future events. So we ask you if you can please complete the survey that you'll receive in an email in the coming days. All of our incredible research is funded 100% by you, the public. If you took something away from this session or were inspired by what you heard, then all donations to support our life-saving work are very much welcomed and appreciated. There's a link to donate in the chat box, should you wish to do so. This edition of Heart Matters Live was recorded and will be available on our YouTube channel from next week. Our next event, Arrhythmias, Understanding Abnormal Heart Rhythms, will take place on Tuesday the 3rd of November at the same time of 1 to 2 p.m. Don't miss out. Register now using the link in the chat box. Thanks again for joining us, and goodbye. Thank you.